Hi, Dr. Athirav.
Hello, can you hear me?
I can hear you. Will you try sharing your screen once, please?
I will, yeah. Can you see?
Yeah, I can see.
I'll just make it a slideshow and change slides. Is it okay?
Yeah, perfect. Thank you.
Yeah. Okay, thank you.
Hello.
Hello, sir. Good afternoon.
Hello. Good afternoon. Good afternoon. Welcome. Welcome.
Good afternoon, sir. How are you?
Yeah, fine. Fine, Athira ma'am. And hello, Akshita.
हेलो डॉक्टर जयपुर से और कोई भी ज्वाइन करेगा अभी तो आप प्लीज ये जूम लिंक भेज दो जो मैंने आपको भेजा है ना ये
Okay.
वाला लिंक भेजना है प्लीज
ओके
हाँ जी प्लीज
अभी तक मेरे को एक्चुअल में वो जो लिंक भेजा है ना वो यूट्यूब वाला लिंक है आपने
वो
जो
भी
भेजा था
सही
ना।
है बट अगर आपकी कोई टीम से ज्वाइन करेगा सेक्रेटरी या कोई भी तो
Okay.
प्लीज आप ये लिंक भेज दीजिए किसी भी व्यूअर को ये लिंक भेज सकते हैं आप
ओके ओके ओके
हाँ जी हम सेशन स्टार्ट कर सकते हैं आई होप आपके पास डॉक्टर का सीवी है
नहीं, आप मेरे को एक बार शेयर करेंगे।
अच्छा एक सेकंड
यू विल शेयर, आई विल, है ना।
डॉक्टर अथीरा हैव यू शेयर्ड इट इन द ग्रुप ऑलरेडी
My
No.
CV?
yes
Yeah.
No,
Yeah,
I
please.
was not asked to share. You want?
can you please share
I'll share it right away. One sec.
Okay.
Yeah, I have shared it in the group.
Yeah. No, in group
Okay,
you
I'll
also share. You share with the PPT mode. I think you will share. Start.
But that's a Word document, sir. They haven't asked me to make
No,
it.
Okay.
no, doctor, it's fine. Dr. Sanjeev, I'm sharing the
Yeah, please.
CV with you and then you can start, please. Sure, doctors, we can start the session.
Okay.
Yeah. Yeah, I think you can start the share. On behalf of very good afternoon. On behalf of IAP Jaipur, I heartily welcome the guest speaker, Dr. Athira Ravindranath, on this the very important topic in our office practice, the role of probiotic in dysbiosis. I think this is the much needed topic in our daily practice, and Dr. Athira is well known in this field, and I think uh, she's from at present in the government Kipam Medical College Chennai, and she did his MBBS from the Chennai and post graduation from All India Medical Institute of New Delhi, and DM Pediatric Gastroenterologist Sanjay Gandhi Postgraduate Institute of Medical Sciences SGPGI Lucknow, and here she has the vast experience in the various medical colleges, so many award and prizes is best speaker award in pediatric gastroenterology literature festival in Espagan, Kolkata in this year only, and selected for the liver transplant school by the Espagan at Netherlands, and in last year I think she has the one of the key speaker and key person to the right choice for this topic. So now over to Dr. Athira Ravindranath for this very important topic. Over to you.
Thank you very much, Dr. Sanjeev Gupta, for that kind introduction. And thank you, IAP Jaipur, for this opportunity. So without wasting much time, I think we can go directly to the topic where we are going to discuss about the role of probiotics and what is its practical utility in our day-to-day practice with routine diseases that we say every day, not very complex cases. And here we are trying to answer every question with the help of literature. It's not about what I feel or what somebody else's feels or my experience. It is exclusively based on robust literature and the meta-analysis which are already published in index journals. So shall we start the presentation, sir?
Yeah, please.
I hope you can see my screen now.
Yeah, and in the slide mode, not in the slide mode. Yes,
Now?
Yes.
Okay. So what is the role of probiotics in dysbiosis and how do we choose an ideal probiotic? So if you just type probiotics and children on PubMed, if you see the date-wise allocation, you can see 3,480 results between 1983 and 2020. So in about 4 decades, they've published about 3,500 articles. Whereas now, within 2015 to 2023, we have almost equal number of articles, about 3,000 articles published. So meaning to say there's a renewed interest in probiotics in various childhood problems. But is this actually true? Is it just a hype, or is there some relevance to this? So is it a hip or a hype? So that is the final conclusion, going to be the final conclusion of this webinar, whether the probiotics that we are seeing, which we are seeing marketed in the in a big way, and whether these are useful, and which one is useful for which disease, and what is the relevance of each probiotic. So we are going to understand which probiotic, at what dose it's going to be useful, and in which condition is it going to be useful, and is it supported by robust evidence or not. That is our target today. So what determines whether it's a hip or a hype is first the disease in question. Is it useful in infections? Is it useful in allergy? So we're going to talk about each disease separately. And then what type of probiotic, which particular bacteria, which particular fungus in the probiotic is useful, whether a single probiotic or multiple combinations of probiotics are also available, whether they are also as useful, what dose is important, and which strain, because many of us don't even read what is there in the probiotic combinations because the long names and the strains which are written in the form of numbers. So here we will at least try to understand the important ones so that we don't forget these names. And the next time we see a probiotic, we'll at least look for these names, if it is there or not, and what is the dose of that particular strain. Next, we're going to understand the credibility of the scientific data. Where was it published? What type of study was it? And is it a systematic review meta-analysis or a standalone RCT? It's also dependent on a lot of other things, how they have analyzed the study, whether there are any biases in personal observations, and what is a placebo effect, which we tend to ignore in most of the studies. And to be very frank, many of these studies are promoted by the pharma companies, so we really don't know whether the results are applicable in the real life scenario. So it's basically trying to look at the question with a half cup scenario. So is it half cup full or half empty? So this is how we have to analyze every study that has analyzed the effect of probiotics in different conditions in childhood. Now, why are we confused? Why are we having this webinar today? Because we really don't know what exactly we are prescribing in what condition, and we don't know which is going to be useful and going to make a difference. So always, whenever we read a study, we should look at the disclosure statement of these people who have written the study, okay, of the recommendations and reviews, because that will give us an idea whether there is some bias involved in the results of the study. And most of the positive outcome studies are funded by the pharma companies. So again, you should look at the acknowledgement section and funding source. And if we are looking at meta-analysis, we should also give importance to the forest plots, okay, and lack of own data. That's again the biggest drawback in the Indian scenario, with except for few studies which we have done in India. Otherwise, there is paucity of research and there's paucity of funds to create that kind of large-scale studies to assess the effect of the probiotic. And we are entirely dependent on Western data in most of the conditions. So probiotics in children is important because the gut forms a gateway. It's a gateway for not just infection. It's a gateway for a lot of other things to induce our immune system. So allergy and immunity is closely linked to the gut microbiota. A lot of functional disorders are also linked to the gut microbiota. And of course, your own genetics will determine what is happening to our gut gateway. So why a particular child is predisposed to allergy and not the other one, and a particular child is predisposed to infection, not the other one. Everything boils down to the gut microbiota. There is a saying that human beings are actually parasites on a body of of a lot of microbes, because the number of human cells is almost equivalent to the number of microbial cells, or even lesser. So that is why it's that's the reason for our failure to actually understand the effect of these bacteria in the body, because we don't even know what is normal. And only if we understand what is normal, we are going to understand what is abnormal and treat that abnormality. So the area of gut microbiota is ever evolving. And so whatever I talk today may not be relevant 5 years later, but today we're trying to look at the currently available literature, which will help in our better understanding. So when we are not even sure about the normal bacteria in the gut, we really don't know which probiotic is going to help you in a disease state. But still, we have some idea of the good and the bad bacteria. And that is why we have tried to mimic those good bacteria in the various probiotic formulations. And our job is to assess whether it is going to be useful in a disease condition or not. Now, probiotics can be used either as therapy or as prophylaxis. So when it is used as a therapy, we have to look at the efficacy, whether it has made any significant difference. Say if it's used for diarrhea, it has to make a significant difference to the child and the family. The diarrhea has to reduce not by few hours, it has to reduce by few days at least. And when it is used as prophylaxis, again, we look at the efficacy, but what's more important in therapy and prophylaxis is the safety, because we are well aware of a lot of reports of fungemia and bacteremia, which can be triggered by use of probiotics, especially in an immunocompromised child. And hence, probiotics should also be considered as a drug and used with all the precautions that we use, that we have in using any other drug. So it is not just a supplement. It's not like a nutrient supplement. We should be aware of which probiotic that we are using in which condition. Now let's go one by one to each disease. So the most important condition that neonatologists encounter is necrotizing enterocolitis. So why does it happen? A lot of theories are there. First of all, the intestinal barrier is immature in a preterm child, and hence there is immature gut immunity. There is altered gut microbiota, which will again lead to translocation. And after translocation, it can lead to sepsis and also contribute to late onset sepsis. So can we prevent NEC and LOS, late onset sepsis? This is our attempt to prevent it. Okay, so the incidence of late onset sepsis is about 20% higher in very low birth weight babies, and it varies between 22.6 to 28%. And can we prevent the poor outcome associated with necrotizing enterocolitis? Again, this is our attempt to do that, because about 50% of grade 3, grade 4 NEC will require surgery, and 20 to 30% may end up with death. And there is a worse outcome in preterms because acquisition of normal microbiome is slow, and the diversity of the microbiome is also poor. Okay, most of these babies have a high volume of Enterobacteriaceae and less of Lactobacilli and Bifidobacterium. So here I am laying the first stone for our understanding of the good and the bad bacteria. So remember these names, Lactobacilli and Bifidobacterium, and Enterobacteriaceae are not good for the gut microbiome. Now let's just look at this case where a 2-day-old female infant born at 34 weeks presented with bloody stools, with no major blood loss during delivery, no bloody discharge from the mother's nipples, and exclusively breastfed. So at least we know it is not swallowed blood. We know it is not cow's milk protein allergy. So which factor do you consider most likely contributing to the 2-day-old preterm infant's bloody stools? Is it maternal health during pregnancy? It can affect the gut microbiome, but not entirely. Is it a delivery-related factor? Yes, vaginally delivered infants' microbiome is definitely different from a cesarean section. Breastfeeding and formula feeding practices will definitely affect the gut microbiome. And possible GI issue, yeah, is there a CMPA? Sometimes it can happen even in an exclusively breastfed baby. Now, why are we confused about the use of probiotics in necrotizing enterocolitis? We had Cochrane reviews and meta-analysis every year coming up with very, very different views. Why is it so different? Because there is a lot of heterogeneity in the various studies. One, the postnatal policy is different. When was it initiated? Was it started as a prevention or was it given as a treatment? If it was given as a treatment, on what day was it given? What strain was used? What was the dose? And what is the duration? And what was the gestational age of the baby and the birth weight? And barring all these things, we know that there are multiple interventions in a preterm baby, and what caused the change, we don't know, especially when we are looking at mortality as the endpoint. Now, when we look at a systematic review and meta-analysis, in 2018, there were 51 RCTs which were included in this meta-analysis, including about 11,000 preterm infants. It was published in JPGN in 2018. What did it show? So here, this table is busy, but still I'm just showing you. It looked at mortality as an outcome, NEC grade 2, grade 3 as an outcome, late onset sepsis, and time until full enteral feeding. Okay, fair enough outcomes, but look at the number of studies included. They're all in single digits. The maximum was 6 studies, okay, and the strains included are given in the first column. Did it make a difference? So when you look at mortality, there is a different risk ratios about 1.1 to 0.2, etc. And NEC grade 2 to 3 is also almost the same. When we look at time until full enteral feeding, it only reduced the time by about 3 to 4 days. But when you look at Bifidobacterium longum and Rhamnosus GG, it reduced it by 10 days. And that's kind of interesting because it is significantly reduced the time to enteral feeding. So do you agree that probiotic is safe for a preterm with NEC or not? As alluded to earlier, we really don't know, okay? But the ideal probiotic should not produce any D-lactate, and it should not have the propensity to develop any antibiotic resistance. And you should have a lab to detect fungemia, whether you're using a probiotic containing a Saccharomyces boulardii or not, but still you should have a lab. And you should look at the purity, viability, antibiotic susceptibility of the probiotic that we are using. And the ESPGHAN says that before using a probiotic in a preterm, it's important to get an informed consent from parents, just like how we get it for other major procedures. And do you think the parents are going to understand about the safety of probiotics? It's very unlikely, at least in our country. Now, let's look at which probiotic, okay? So we have Lactobacillus rhamnosus GG, ATCC 53103. You have to remember these numbers. So doses, at least if you don't remember the first number, 10 power watt, okay? That's important. So here they have used 10 power 9 colony forming units. And here it reduced NEC stage 2 or 3, and it has a low certainty of evidence, but still they recommend it. What happens to the combination? They've used Bifidobacterium infantis, lactis, and Streptococcus thermophilus. Here they have used 10 power 8 CFU of each strain, and this also reduced NEC stage 2 or stage 3. But still, they have not significantly recommended these probiotics, and optimal duration is not known, but still most of the studies use about 4 to 6 weeks or until discharge. So remember, Rhamnosus GG, ATCC 53103, or a combination of Bifidobacterium infantis, lactis, or Streptococcus thermophilus. Now, let's look at the other probiotics. Lactobacillus reuteri DSM 17938, okay? This is not useful in at least NEC prevention because it's partially D-lactate producing strain. Now, here we have to look at it with a pinch of salt because ESPGHAN says this reuteri DSM 17938 is not recommended because of the D-lactate production. However, this same Lactobacillus reuteri DSM 17938 is used in treatment of infantile colic. So will that not produce D-lactate, or is it dependent on the gut immunity? So is it only predisposing the preterm infants for D-lactate production? We don't know. But there is absolutely no evidence to support Bifidobacterium and Lactobacillus acidophilus combination or Breve combination or Saccharomyces boulardii combination, especially in a child with central venous catheter, critically ill or immunocompromised because of the risk of fungemia. So no Saccharomyces boulardii. If you really want to use, you can use Rhamnosus GG or a combination of infantis, lactis, and thermophilus. Now, that was for treatment. Now we are looking at prevention. So how can probiotics prevent NEC? It can prevent it in there is an overall reduction by about 3.5% and gut-associated sepsis by about 15% and 5% reduction in mortality. But the number needed to prevent one late onset sepsis is 44. That is, you have to treat 44 children to prevent that one single case of late onset sepsis. And the best outcomes as per the previous studies is in children less than 32 weeks and less than 1500 grams. Now, AGA has a conditional recommendation of using a combination probiotic in low birth weight infants for treatment as well as prevention of NEC. Now, what are the gaps in research in preterms? One, placebo-controlled studies are difficult to do because otherwise you will not be able to do a head-to-head comparison. And the dose and time of initiation, duration are different in every study. And we need more data in very low birth weight babies, less than 28 weekers, less than 1000 gram babies. And it is also dependent upon the quality of enteral feeding. Some babies may be on mother's milk, some may be on donor milk, some may be on formula milk. So we have a lot of heterogeneity, whether it is administered in the powder form or liquid form. And what is a long-term safety? What is the effect on immunity, endocrine, metabolic, and behavioral outcomes? And demography, of course, gender and ethnicity, cultural practices, all these things will have an effect on the ultimate outcomes. So with so many confounders, we only have so much evidence to support our use of probiotic. So at least we have some evidence. Now, is there any evidence for acute infectious diarrhea? Then here again, the world is divided into two. In most of the European countries, they actually promote using probiotics, whereas in Western Europe and North America, there are opponents for using the probiotics in acute infective diarrhea. And what about Asia? Again, there's so much of heterogeneity, we really don't know, but this is the ideal place for research because of the caseload and the severity of diarrhea in these countries. So we can actually make important research findings if we conduct it in a proper way in our country. Now, what is the reason for heterogeneity? Again, it depends on a lot of patient factors, the country that they are living in. Okay, what is the severity of the diarrhea? Is it bacterial versus viral? What is the immunization status? What is the nutrition status? Immunization, especially what is the status of rotavirus vaccination? And intervention factors, which day of diarrhea did we introduce a probiotic, whether it's a single or a combination. Again, the same thing, strain, dose, duration, all these things will affect the final outcome. Now here, there's a 3-year-old child coming with acute gastroenteritis of duration of 1 day. Now the child is also having pain abdomen and otherwise the child is not dehydrated. So what do? Will you continue the probiotic prescribed elsewhere and closely monitor the patient's symptoms? Or will you try to find out a potential etiology or consider adjusting the dosage or switching to a different probiotic or just provide supportive care? Okay, if you ask me, I would just provide supportive care and I wouldn't start any probiotics or continue them. But what does literature say? Okay. Now we have to look at the efficacy of probiotics. So for the mother or the treating physician, duration of diarrhea has to reduce, volume of stool has to reduce, and duration of hospitalization has to reduce. Then it's an appropriate intervention. Just like how we talk about green banana diet, where it has produced significant changes in the diarrhea-related outcomes. So for research purposes, we are using the modified Vesicary scale, which is going to look at the diarrhea, the volume of the stool, the duration of the stool, vomiting, whether there is fever or not, and the severity of dehydration. So if you're going to do a research, we are only looking at the Vesicary scale, but practically it has to have some impact on the duration of hospitalization and diarrhea in days, not in hours. So what does the Espegan say? Okay, there is a weak recommendation for Lactobacillus rhamnosus GG, Saccharomyces boulardii, Reuteri, Clossy, Helveticus, rhamnosus plus Reuteri combination, all these things are not useful. So weak recommendation only for these, that is rhamnosus GG, Saccharomyces boulardii, Reuteri DSM 17938, the same strain which this is the most important strain of DSM. So please remember this number 17938, and Bacillus clossy still has only a very, very weak recommendation. Now, what does the American Gastroenterology Association say? There are about 85 trials for acute infectious diarrhea. What did it reduce? It reduced the duration of diarrhea by about a day. Maximum is 28 hours by Saccharomyces boulardii. So overall reduction is about 22 hours reduction in the duration of diarrhea. Is it significant? Not really. Okay, so in children with acute infectious gastroenteritis, AGA recommends against the use of probiotics based on the available evidence. Now, when we look at the RCT involving Lactobacillus rhamnosus GG, did it have any difference? No, no benefit in acute diarrhea. The other strain, Helveticus plus rhamnosus combination, again, no benefit. Okay, let's just forget all these numbers, but the final verdict is that there is no benefit. Now, predominantly, so even if the authors said that, yeah, there is some benefit in the reduction, but see, look at the p-values, none of it is significant. Even in this table, here also, except for vomiting duration, which is 0.0, where the p-value, sorry, this is not the p-value, except for vomiting duration, nothing else had any important difference. So predominantly, most of these trials had milder severity patients, and both of them were conducted in North America, and where majority were immunized for rotavirus. And stool samples were tested in about 80% of these children, and 50% of them had viral etiology. And the probiotic was given after 48 hours of onset of diarrhea. So is it the probiotic which made the difference, or was the gastroenteritis already settling? And all of these had administered the probiotic in liquid form. So the viability is questionable. And antibiotic exposure in a subgroup may affect the gut motility and the non-efficacy. But still, the final verdict is that both of them are negative for supporting the probiotics in acute diarrhea. Okay, again, Lactobacillus rhamnosus GG also, in the European perspective, there is not much of a significant reduction, but this is a European perspective. There is a reduction of diarrheal duration by 0.85 days. That's again about 21, 22 hours. But the one thing that we have to remember is at least the dose should be more than 10 power 10 colony forming units. Okay, and there is a reduction in hospitalization by 1 day. But this happened in Europe. What happened in India? Here, it reduced the duration by 24 hours. Again, higher dose is better and more effective when it is introduced within 72 hours of diarrhea. And it is actually better in rotaviral diarrhea. Since rotaviral vaccination is not universal in our country and many of the children still have rotaviral diarrhea, at least we found that, okay, there is slightly better outcome in rotaviral diarrhea from the Asian countries. Now, how about Saccharomyces boulardii? No, stool volume is not evaluated in any study, but it did reduce the number of episodes of diarrhea between day 2 to day 7. So it reduced up to 7 days of diarrhea. Bacillus clausi again reduced it by only a few hours, and recovery of diarrhea was achieved by 97% of the patients, which can be achieved even without a probiotic. So but what is important is that the total treatment cost increased by 472 rupees when we use a probiotic vis-a-vis ORS alone. So is it affordable for most of our population? See, diarrhea itself is more common in the low socioeconomic status. So can they really afford Bacillus clausi and other probiotics? And is it really cost effective? I don't think so. So at least even the studies don't support this thing. Okay, and when it comes to Lactobacillus reuteri DSM 17938, there are no Indian studies using this strain, but even in the other studies, there is considerable heterogeneity. Okay, there is reduction in hospitalization by half a day and reduction duration by about 0.87 day, or about 3/4 of a day, which is not very significant. So when you look at the Indian studies, we don't have anything with respect to reuteri, but rhamnosus GG, boulardii, and clausi, there is some benefit in all with only a moderate level of evidence, but it's going to increase the cost by at least 500 rupees per day. And combination probiotics are found to be unsuitable in reducing acute diarrhea. But brief result with reference at the poor impact on the overall outcome But yes, statistically, it may be a little significant by few hours, but still the existing level of evidence is very low to moderate. Now, how about other diarrheas? Okay, the most important ones are antibiotic-associated diarrhea, Clostridium difficile diarrhea, nosocomial, and inflammatory bowel disease. So, is the probiotic supplementation going to reduce the incidence and severity of antibiotic-associated diarrhea, Clostridium difficile, nosocomial diarrhea, or exacerbation of symptoms in IBD? Let us see. So, to prevent Clostridium difficile infection, the American Gastroenterology Association recommends everything. That is, either you use Saccharomyces boulardii, 2-strain combination, or 3-strain, or 4-strain. They have recommended it conditionally, but with low quality of evidence, and also administered caution in immunocompromised children, and also to consider the cost. But still, we don't know when to give, whom to give, and how long to give to prevent a Clostridium difficile associated diarrhea in children receiving antibiotics. So what is the role in other diarrheas? Yes, is the only place where it is useful in a diarrhea, which is beyond doubt, is a pouchitis after colectomy in patients with ulcerative colitis. So where the whole colon is removed and we make a ileal pouch anal anastomosis, which can get inflamed with time. Only in that condition, VSL-3 is recommended. There is no use of probiotic in treatment of Clostridium difficile infection, either single or recurrent. If there is Clostridium difficile, you have to treat with either metronidazole or oral vancomycin. Sometimes some people may even require a fecal microbiota transplant, but no role of probiotics as of now. No role in any IBDs, ulcerative colitis, Crohn's disease, except for this condition of pouchitis, and no role in the treatment of persistent diarrhea. There's no confusion here. Okay. And next is for preventing nosocomial diarrhea. Here, Espegan says that Lactobacillus rhamnosus GG may be recommended for preventing nosocomial diarrhea in children, that too at least 10 colony-forming units per day for the duration of hospital stay, 10 per 10 actually. Lactobacillus reuteri DSM is not recommended. Now that's about diarrheas. Next, let's look at the pediatric allergies. Okay, so we know that allergies happen because of an alteration in the gut microbiota. So can we give probiotics to alter the gut microbiota to prevent allergies? So we look at food allergy, atopic dermatitis, eczema, allergic rhinitis, and asthma. So what is the current evidence regarding the use of it? So optimal strain, dose, timing, none of it is clear to us. Okay, so we really don't have any evidence to support probiotics. Now let's see, use of probiotics in pregnancy and infancy reduce eczema, atopic dermatitis? Some meta-analysis say no, some of them say yes, with low evidence. But will it reduce food allergy and asthma? No. It's not going to reduce any food allergy, asthma by just giving probiotics in pregnancy and infancy. Next, coming to functional GI disorders. So we would have heard a lot about probiotics in infantile colics. So we'll look at that. Functional abdominal pain, because we are left with almost nothing to treat them. People have tried probiotics. IBS, that is irritable bowel syndrome, regurgitation, constipation. In all the functional disorders, probiotics have been tried. But where did this stem from? Because people now say that all the functional abdominal disorders are actually microorganic diseases. That means we don't find any major problem when we do a ultrasound or when we do a colonoscopy, endoscopy, but still they have something going wrong. And many of them have attributed it to an altered gut microbiota. So will the alteration of the gut microbiota go back to normal when we use probiotics? Let us see. So infantile colic. So this is a summary table looking at the effect of Lactobacillus reuteri in treatment of infantile colic. That is, colic has already set in. Is it going to help the child? So here they have used both, included both breastfed and formula-fed infants. And most of them a placebo-controlled trial, and in an identical formulation but without live bacteria, and they treated for about 3 to 4 weeks. What did they find? And all of them use Lactobacillus reuteri DSM 17938. It's inconclusive in breastfed infants, but it is not useful in formula-fed infants. So It's not at all useful in formula-fed babies, and when it is breastfed, when the baby is breastfed, it is inconclusive. So we don't have anything positive to support it. Now, is there any evidence in preventing the colic, regurgitation, functional constipation, that is before the onset itself? So let us look at the primary outcome from this study, where they looked at Lactobacillus reuteri, DSM 17938. Okay, they used 5 drops from birth to about 90 days and followed up these babies for about 3 months. And 50% were exclusively breastfed, 50% were formula fed. Okay, so what happened at 1 month of life? When you look at the colic, the ones who received probiotic, the colic duration reduced to 45 minutes vis-a-vis 96 minutes in the placebo, which was significant. Regurgitation, it was 2.7 in Lactobacillus reuteri and 3.3 in the placebo arm. The p-value was not significant, and the number of evacuations was 4. This is for prevention of functional constipation. That is why they are looking at the number of evacuations. And 2.8 in the placebo group. Here the p-value was significant. Again, this is only outcome at 1 month. What happened to these babies at the end of 3 months? All of them became significant. That is, colic episodes reduced by half and about 40 minutes in Lactobacillus reuteri, and it lasted for about 70 minutes in the placebo. Regurgitation was about 3 episodes per day and 4.6 episode placebo. It doesn't make really much of a difference, but the p-value is significant. Number of evacuations also. See, look at it. It's 4.2 per day and 3.6 per day. Does it really make a difference practically? Not at all. It's just the statistics that the p-value is shown to be different. But yes, infantile colic, it did show some significant difference, because a child crying for 40 minutes is any day better than a child crying for 1 hour, 10 minutes. And what happened at 3 months of life? So at 3 months, they looked at the other outcomes. How many visits to the pediatrician? How many visits to the emergency department? And how many days did the parents lose working? That is, how many loss of parents' working days? And use of other medications like simeticone, simetropium, use of other natural herbal products, okay, and feeding changes. So did any of it change with supplementing Lactobacillus reuteri compared to a placebo? Yes, the number of pediatric visits reduced to 1.3, placebo is 2.3, emergency visits from 0.5 and 1.78. Loss of working days, half day to 3 days, 3 days and half day. Okay, and the use of other drugs also significantly reduced. Feeding changes did not occur in majority. So most of these parents stuck to the same feeding regimen. So there is some difference in reducing colic when we use the probiotics as a preventive measure. Now, is there any use in irritable bowel syndrome and functional abdominal pain? Multiple studies, they've used different probiotics, okay? And they have done it very diligently. So they have used a placebo, then there was a washout period for 2 weeks, and then they use a probiotic intervention. Similarly, the other way around also. But here again, the quality of evidence is very weak, and it is not recommended in irritable bowel syndrome and functional abdominal pain as of today with the available evidence. So what do we look at? Based on the conclusion of all these studies, the high to modest evidence is for preterms for NEC, and combination strain is better, with at least 10 CFUs should be available, should be given per day. Okay, and antibiotic therapy for prevention of C. diff, yes, you can use single or combination with some sketchy information. Pouchitis with VSL-3, yes, definitely it is found to be useful in patients with ulcerative colitis after a colectomy and ileal pouch anal anastomosis. So when you have a preterm, you can use it for NEC, whether it is for treatment or prevention. Yes, there are some studies supporting both. So, and until now, it is not recommended to use Saccharomyces boulardii, especially in an immunocompromised child, because of the risk of fungemia, and even when there is a presence of central venous catheter. And for preventing C. diff diarrhea, you can try, that is for preventing nosocomial diarrheas. Low to poor evidence in acute diarrhea, where they have used all of them, Bacillus clausi, Rhamnosus GG, and Saccharomyces boulardii. You can maybe try, but there is a paucity of powered studies, and not much of a difference in eczema, atopy, and infantile colic. Yes, only with Lactobacillus reuteri DSM 17938, it reduced the duration of colic, and this reduction was significant even at 3 months of age. So you can actually use it for preventing infantile colic also, but there's absolutely no use of probiotics in IBS, functional abdominal pain, any kind of food allergy, persistent diarrhea, inflammatory bowel disease, or in the treatment of Clostridium difficile therapy. So again, I'm reiterating that you may use to treat or prevent NEC, you may use to prevent nosocomial diarrheas, and for treatment of pouchitis. Pouchitis are very rarely seen. They won't come to our OPD so commonly. So, but at least for NEC and preventing nosocomial diarrheas, yes, you can try. For infantile colic, at least based on the evidence, yes, it does reduce the duration of the colic and the number of emergency visits, but not much of benefit in acute diarrhea, eczema, and atopy. But yes, that's because of the paucity of Howard studies, and absolutely not useful in the other conditions. So that brings us to the end of the webinar. And I hope we didn't bombard you with a lot of literature, because there's no other way that we can actually look at it very objectively. So this slide recommends the summary. If there are any questions, I'm happy to take.
Yeah, I think it was the wonderful talk, Athira, as you talk in the, you tell all the indication about the probiotics. And I have two questions for you.
Yes.
One is, as you already told, that the probiotic role in the prevention of NEC, right?
Yes.
So, and the microbiota is the very much different in the normal vaginal delivery versus the cesarean section.
Correct, correct.
So, is it right? Is it okay? So, in all the cesarean preterm delivery, we can start the probiotic?
Based on the evidence, yes, it can prevent NEC, but again, all the evidence-based data is very, very sketchy, sir. So we cannot give a recommendation like that. But even Espegan has given only a conditional recommendation for preventing NEC. But at least when we look at the other indications, only in NEC there is some benefit of probiotics, and without much of a side effect. So carefully we can select a probiotic, and then we can attempt using it. But again, we all need further studies for proving it. Okay.
So that means, in case a very high chance of NEC, like in the preterm baby or the sepsis child, or all the risk factor on the NEC. So when we are thinking about, is it any guideline about the weight of the child, or the gestational or the gestational age, so we can start timely before developing the NEC or as a prevention? Yeah.
Yes. So the data is robust in babies about 32-34 weeks, and around 1,500 gram babies. The data is robust, but less than 28 week and less than 1 kg, the number of babies of that cohort, of that age and weight, was very less in most of the included trials. So, but at least in slightly older babies, you can start as a preventive measure. But we know that the severity of NEC is also more in younger babies with lower birth weight. So it's a tough call to take. But as of now, at least there are no major side effects reported. So we can still consider using probiotics.
And now my second question, you can stop your slide sharing.
Yes.
And now my second question, what about your take-home message for now the lot of companies and lot of the molecule is come up with for
yes, sir.
Allergies is the rise. So what about your key message for the allergy, including all the type of, including the atopic dermatitis or the prevention of the allergy, like allergy rhinitis or asthma?
As far as probiotics are concerned, there is no role for preventing any sort of allergies with respect to probiotics. But from a very generic point of view, we are seeing a lot of allergies coming up nowadays in children compared to what it was before. As a gastroenterologist, we are seeing a lot of cow's milk protein allergies also coming up. So because of the change in the dietary patterns in ourselves and in our children. So my recommendation is no probiotics, but to prevent allergies, stick on to our routine Indian diet, avoid processed foods, avoid formula feeding. So because we are seeing a lot of CMPAs even in exclusively breastfed babies. So that is because of the mother's microbiota also. So as responsible individuals, we should just stick on to our traditional food, which is going to help us reduce the number of allergies.
But since last 1.5 year or 2 years, a lot of the molecule has come up, and they're claiming, right, in the especially in the probiotic, the so strain is the benefit in the prevention of the allergy rhinitis or the recurrent allergy disease.
Not at all, sir. At least as far as the evidence goes, none of the probiotics are found to be useful in preventing allergies in these children. So yeah, I don't think as of now we should resort to probiotics, but things may change in future.
Yeah, and and we all know about the role of probiotic in different type of diarrhea, right? But yes, apart from that, the role of in the probiotic in constipation.
Constipation, again, there is no role as far as evidence is concerned, and even practically, constipation is arising more because of the habitual changes. Children are not toilet trained, they're not having adequate fiber in the diet, and because of all these things, use of diapers for a long time, they're not toilet trained at the right time. Because of all these things, constipation is on the rise and failure to treat it at the right time. So I think if we address those problems, it's going to reduce rather than adding a probiotic to the diet.
Okay. And what do you think that just as we all know about the antibiotic associated diarrhea, so we are already started the antibiotic and the diarrhea is started. So what is the right time, especially in the kids less than 2 years, what is the right time to start the probiotic when we are prescribing the antibiotic?
Yes, sir. So for antibiotic associated diarrhea, as far as the evidence goes, you can start a probiotic to prevent an antibiotic associated diarrhea. At least for that, there is some moderate quality of evidence. But once the diarrhea has started, then the probiotics are not going to reduce it very significantly. If you see the studies, it will just reduce it by a few hours, which is not very significant. But yes, in any child who's more than 1 year of age, who's getting antibiotics and then diarrhea setting in, we have to check the stool for Clostridium difficile, toxin A, toxin B, and treat it. If it is positive, we treat with metronidazole or oral vancomycin rather than giving a probiotic as a treatment. But for prevention, yes, there is some role of adding the probiotics when we start the antibiotic. But in children less than 1 year, Clostridium difficile will not cause diarrhea because they don't have the receptors for the toxin. So we don't have to check for Clostridium difficile in less than 1 year. And in many of these babies, it may be a commensal. So in less than 1 year, it may be just an increased motility, which is causing the diarrhea. Like say, if we are using augmentin, amoxicillin, clavulanic acid, it may just increase the motility, azithromycin. So the mechanism may be different. And probiotic will help only if there is a change in the gut microbiota. So for prevention, we can use the probiotic, but not for treatment.
Thank you so much. Very nice information as you already shared. And I think it was the wonderful talk. Thank you. Thank you, Athira.
Thank you, sir. Thank you. Thank you, Akshita.
Akshita, any question in chat box? Akshita? I think it is all about the role of probiotic in dysbiosis.
Yes.
So I thank you so much, Athira.
Thank you so much, sir. Thank you so much for your patient listening. Thank you.
Thank you.